Kia ora, welcome. I'm Adele Gauthier from Breast Cancer Foundation NZ, and tonight we're talking about HER2 positive breast cancer. So what exactly does HER2 positive mean, and what difference does it make to your treatment if that's the kind of breast cancer you have? Well, that's what we're about to find out. We have three panelists who will share their knowledge and experience of this particular type of breast cancer with you tonight. So let me introduce you. With me here are two patients, Sarah Gandy and Ellie. And then we have medical oncologist Dr. Sheridan Wilson. Now, before we get started with the panel, just want to give you a heads up about some of the drug names you'll hear tonight. You might well have heard of Herceptin, which is the brand name of a commonly used drug in HER2 positive breast cancer. Tonight, you might also hear the words trastuzumab, that's Herceptin's chemical name, the unbranded name, and also Herzuma, which is a newer brand of trastuzumab. So basically, when you hear any of those, we're talking about the same thing. Right, first up, we're going to hear from Sarah Gandy. You might not have seen Sarah before, but there's a chance her voice will be familiar to you from her work as a radio host and podcast host. Sarah was diagnosed with HER2 positive breast cancer in 2018 at age 36. Sarah, thanks so much for being here tonight. Tell us a bit about your story and the treatments that you had.
Thanks, Adele. So as Adele said, I was 36. It was the end of, actually, I found my lump in 2018, but it was January 2019 when I was launched into the world of breast cancer. So I was diagnosed with a mammogram, ultrasound and biopsy. And my diagnosis was HER2 positive, ER positive, and PR negative. What they found was two tumours in my right breast. One was just under 8 centimetres by the time we got to active treatment stage, and a small spread to my lymph nodes. It's technically an infiltrating ductal carcinoma and some DCIS. And I'm going to be honest, I had to look this all up again because it's been a hot minute and I've forgotten all of it. So if anybody's going through treatment right now, just know in a few years' time, all of these words that are probably swirling around your world right now will hopefully be a slightly distant memory. So when I was diagnosed, the thing that happens when you're diagnosed is you get thrown into a million trillion decisions. And I thought I would take you through some of those treatment decisions that I made. The first was whether to go public or private. I initially was diagnosed in public and I started out with my consultations in public, but we luckily had healthcare and decided to see how much of that I could use. So I did actually go private for pretty much all of my care. And I do know people that have kind of gone 50-50 or done certain bits in public and private. So if you have private health insurance, it's always worth looking to see what it might cover. And for me, that did actually make a difference in what I was able to access in terms of treatment. My second decision was whether or not to have IVF. And that was something that I didn't really see coming as a decision when it came to my cancer diagnosis. I was 36, I was married, but I had no kids. And we decided that instead of freezing embryos, we just wanted to get straight into treatment. I had quite an aggressive cancer. HER2 positive is notoriously aggressive. And so the decision was made to just jump on in. The next decision was chemo or surgery first. And, everyone I knew actually who'd gone through treatment had surgery and then gone into chemo after that. But I opted for chemo first, which is neoadjuvant chemotherapy with anti-HER2 therapy thrown in there as well. And the reason I went for chemotherapy first was because I liked the idea that you could track the tumour's physical response. Like I could literally, after each round, put my hand on my boob and feel it shrinking, which was quite an empowering feeling. I also felt like I could attack all of the cancer at once, not just the big lumpy stuff. You could get to the microscopic stuff hopefully as well. And it also gave me a bit of time to make decisions around reconstruction. So I could figure out what was going to happen once I got rid of the old boob, what was happening next. And that meant that eventually I could have a mastectomy and reconstruction all at the same time. So for me, tick, 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 it made neoadjuvant chemo make complete sense. The next decision was what type of chemo to have. And oh my God, there were so many words that I'd never heard of before and a lot of options thrown at me. But what I ended up deciding on was, I call it TCHP. I think probably heaps of people do because who can pronounce these next words constantly? Docetaxel, carboplatin, and then the anti-HER2 drugs, Herceptin and Perjeta, which is also known as the Dr. Sheridan will say that one later, but it's also an anti-HER2 therapy. So I launched into 6 cycles of that. And the other reason I chose that regime was because I was going to be doing cold capping, which is if anybody doesn't know about cold capping, you put almost like a rugby helmet on your head that freezes your hair follicles or your scalp to -4 degrees, and it lessens your chance of losing your hair. So my oncologist had felt that CCHP might give me better success with that potentially, and it worked really well. So all in all, great choices there. The other decision I made around chemo was to have a portacath for the full round of treatment, just to give my arms a break. So that was quite a raft of decisions, and I was only halfway through treatment. Once I got through chemo, the next step was surgery, and I went for a single mastectomy. So I have got one old boob kicking, and went for an immediate DEP reconstruction. And what was pretty amazing about that is because I had surgery after chemo, they could, I'm not going to say this eloquently, dig out all the stuff and test it and see whether there was any remnants of cancer, and there wasn't. It came back what they call no evidence of disease. So that was another really encouraging step in my treatment. The other thing I should mention is that throughout all of that chemo, I was also having Zoladex, which is just ovarian suppression. It throws you into medical menopause, and oh my God, what a hoot it is. But it got me through those 6 months of chemo. Once I'd gotten through surgery, I had 15 rounds of targeted radiotherapy, and then I kept going with the anti-HER2 drugs. So there was a discussion around, once we'd been able to do the pathology check, would I stay on Herceptin or would I go to something called TDM1? And because I'd had such a strong response to the neoadjuvant chemo, we kept with Herceptin. We threw some Perjeta back in the mix for the final 4 rounds. And as you can see by the cat with the lasers, I was really just excited to be getting through my final chunks of treatment. So that was what I call my active treatment. Now, a few years on, I take tamoxifen every day, and I'll take tamoxifen for 5 to 10 years, depending on what my oncologist says. I also see my breast surgeon and my oncologist once a year, kind of 6 months apart. And in terms of what I do, I just really make an effort to look after my body, pay attention to it when it gets grumpy, figure out what have I not been doing so well, exercise, diet, sleep if you can get it. But also I do have to admit, I do the 80-20 rule, where 80% of the time she good, 20% of the time she having fun, because that's why I'm still alive, is to have a little bit of enjoyment in life. So that's where I'm at. When I look back on all my treatment decisions, there isn't anything that I would change. I'm really happy with all of them. Yeah, that's me. Thank you so much.
Great. Thank you so much, Sarah. That was super interesting and helpful for people. Right, so now we're going to hear from Ellie Bhatia, who was diagnosed just last year at age 44. Ellie, thank you for being here tonight. You're still in the thick of things as far as your treatment for HER2-positive breast cancer is concerned. Tell us a bit about your journey and the decisions that you've had to make.
Yeah, sure, and it's lovely to be here. So I self-detected a lump actually at Easter time of last year, randomly in a different city, and turned oddly in a shower and felt something. So more by luck, I wasn't far off being on, being 45, and I hopefully would have gone for mammograms at that point. So I do consider it luck. I went to my GP straight away, and really went through mammograms, ultrasounds, biopsies, and within a couple of weeks I was diagnosed with cancer. To be honest, I didn't really think much at all about the possibilities of cancer at the beginning of this. I've been through a hell of a journey on IVF, and I was just at a place we were lucky enough to be able to adopt 2 children, and at a point in life where I didn't think anything more could possibly go wrong. But anyway, I wouldn't say it go wrong, it's just life, really. So also we didn't have a family history of cancer other than an aunt who had cancer 20 years ago. So it wasn't really top of my mind. And so much so that I took my mum to my appointment for my diagnosis. Not that that's any reflection on my mum, but I didn't have my husband because I really didn't think anything was truly going to be wrong. So anyway, those breast specialists gave me the results. I had a 30, I think it was about 33 mil in the end with this 90 mil tendril. I do this when I do a tendril, but whatever that means, there was something coming out of, it sounds awful, but yeah, so 30 mil with a 90 mil tendril, stage 3, grade 3, and HER2 positive. as well. And they found some later when they did a biopsy on my lymph nodes, found some cells in my lymph nodes as well. So, quite a shock. A few tears and thoughts of my husband and my very young children who are only 4 and 2 at the beginning of this as well. But then I got back to what do I need to know? What do I need to ask? So there were lots of discussions, even in those early meetings, about the options and talking about surgery then, or whether I wanted to go for chemo or neoadjuvant, as Sarah's already talked about. Again, I was lucky enough as well, or privileged enough to have private medical insurance. So I placed a high level of trust in the team of people around me. And this included actively me saying, I will not Google things throughout this journey. I'd done it a lot through IVF and it's not a good place to be. So my experts were my experts and I was going to listen to their advice. So I decided to go with neoadjuvant chemotherapy. And I started that pretty quickly after a couple of weeks of more tests. I had MRIs, CT and PET scans, echocardiograms, portacath insertion as well, and biopsy in there. I decided on neoadjuvant because I was really adamant at that stage that I wanted to reduce the size of the tumour, try and get rid of it completely and actually reduce potentially the amount of surgery that I needed. In fact, my preference at that point was to have a lumpectomy if possible, and depended on what was happening with my lymph nodes as well. I also thought my body's probably at the healthiest in theory at that point. So let's chuck chemo at it now. Let's do that first. That's where I landed there. Also, I understood that HER2 positive, while the tumours grow quickly, they can also respond well to chemo. So I thought, let's get this thing, let's shrink this thing and get rid of it. Unfortunately, my chemo was delayed by a week because I got the other C, which doesn't help and adds to the stress, but we won't go there either. So that, one of my, I think, big takeaways as well, there's a lot of medication, not just the chemo itself, but medication around chemo. I did start to get a bit overwhelmed with names of things, brand names, and still to this day, I confuse things. So again, my oncologist was awesome at describing things and being careful with the delivery of information at the right time. I didn't need to know what was going to happen in 6 months. I needed to know what was going to happen in a month. So there was a lot of information provided there as well. And talking through the difference between Herceptin and Herzuma, and what I was covered for under my insurance, and my oncologist was wonderful in working through what I was covered for, which I ended up also being covered for pertuzumab in there as well. I thought it was funny too, in all my medications I received the drops that are used for glaucoma. Oh yeah, so that my eyebrows and eyelashes didn't fall out, which I thought was a good one as well. So I had issues on chemotherapy on the original protocol, and I switched to AC as part of that, had blood transfusions, you name it. But towards the end of chemotherapy, I was now at a point to think about surgery. And now I was thinking, actually, I don't want to ever go through chemo again if I can avoid it. So I actually changed my mind and said, I'm going to have a single mastectomy. I had residual disease was the term that was used, and moved to have a single mastectomy in December. I also had 20 lymph nodes removed. So in March and April, I had radiation as well. And at the moment, I'm currently on TDM1, which is what is the combination of Herzuma plus something that is going to hunt out all the cancer cells in my body and hopefully eradicate them. So, most of my decisions on this was, how do I extend my life? How do I get the best outcome here? I've got young children. I've got a lot to live for. We've come a long way. So all the things I did were to, chuck as much at me as you want, oncologist and team. I'm here to do it, and I'll listen to what you say, because I do have faith in science and how far it's come. So the next thing for me is to move to biphosphonates. So I've had my teeth checked recently as well, because some rare side effects of that. And I've just switched to letrozole because I had some unusual side effects on exemestane as well. So yeah, that's my journey.
Right, and your ongoing journey. Thank you very much for sharing that with us, Ellie. Now we're going to hear from Dr. Sheridan Wilson, who is the head of breast cancer medical oncology at Auckland City Hospital and also practicing in private here in Auckland. Sheridan, we really appreciate you joining us here tonight. Could you tell us a bit about what makes HER2 positive breast cancer different from other cancers and how we treat it here in New Zealand? Thank you.
Kia ora koutou katoa. This is a real challenge. Usually, if I'm giving a talk about HER2 positive breast cancer, I would have at least an hour and there'd be at least 100 slides to work through. So the challenge is to prioritise some information that would hopefully be of value to those people who have a diagnosis of HER2 positive breast cancer or who perhaps know someone who has this kind of diagnosis. And I think a lot of what I'm going to say, you've already heard a bit about in hearing what a patient journey might look like. To make sure that we all are working with the same information, I'm just going to dive a little deeper into what breast cancer subtypes are. And many of you will have figured out by now that there are different types of breast cancer and we treat them all a little bit differently. And the way that we define those breast cancer subtypes is related to how they look under the microscope. So when the pathologist in the laboratory receives a breast cancer sample, either a biopsy or a tissue specimen from surgery, the sample is inked or stained with special stains that highlight both the hormone receptors and the HER2 receptor. And it's the pattern of these receptors that define our subtypes. The grid that's on the screen for you shows what stained tumour cells look like. And the bottom row is the one of interest. That the two squares in the middle of the bottom row with the dark brown sort of inky blotches on them, that's what it looks like when a tumour stains positive for the HER2 receptor. Flanking those two bottom squares are HER2 negative cancers where the slides just still look kind of purple in colour. They don't have any staining for the HER2 protein. Now, sometimes the immunohistochemistry or the staining of the slides will give an in-between result for HER2, and that requires an extra set of testing, which is a cytogenetic test. In New Zealand, we do a FISH test. It's a different type of test and it gives the pretty picture that's on the right side of the screen. So that's a secondary way that a cancer can be tested for HER2 positivity. It might be interesting to know that not only breast cancers can be HER2 positive, there are also a small subset of lung cancers and stomach cancers that are HER2 positive as well, and they get to receive some of the HER2 targeted therapy that you've already been introduced to. So we tend to think of HER2 positive cancers comprising around about 20% of the breast cancers that are diagnosed. In New Zealand, we do see a slight excess of HER2 positive breast cancers in Pacifica women. So what actually is HER2? HER2 is a receptor which is found on the outside of cells. And what it's made of protein, and it can be normal for it to be there in small amounts. But if there's a bunch of HER2 on the outside of the cell, then that's when it's determined to be a HER2 positive cancer cell. And when there is a lot of HER2 on the outside of the cell, it tells us that the growth of the cancer is being driven by a chain of events that's happening inside the cell, but that starts with activation of the HER2 receptor. So we typically think of HER2 positive breast cancers as being faster growing, and they've also historically been cancers of concern because they behaved more aggressively. Now, that is not how we view them so much these days, because the treatment for HER2 positive breast cancer has really improved outcomes. So HER2 positive breast cancers are characterized by a lot of the HER2 receptor, and this is an indication that the cancer is growing because of HER2-driven events inside the cell. When we're thinking about treating HER2-positive early breast cancer, we're talking about the treatment of cancer that's confined to the breast and maybe to the lymph nodes. And exactly what treatments are recommended will depend on a range of different things. It will include the size of the cancer, what grade the cancer is, whether there's any lymph node involvement, and if the person has any other important medical conditions that might make certain drugs unsuitable. The drugs that we use for HER2-positive breast cancer includes chemotherapy, the same kind of chemotherapy drugs that are given for HER2-negative cancers. But what's special in the treatment of HER2-positive cancer is the targeted therapies. And for early breast cancer, that's predominantly drugs called monoclonal antibodies, which is the Herceptin, Herzuma, and the pertuzumab or Perjeta drugs. And then antibody drug conjugates, which are a newer class of drug, and that includes drugs such as TDM1 or Kadcyla, as Ellie's referred to. The chemotherapy drugs, some of you will have come across them. There's the anthracyclines, which are often known as the red drug. There's the taxanes, which come from the Pacific yew tree. And these are arguably our most active chemotherapy drugs in breast cancer, but they're not the only ones. And then we have the antibody drugs, the antibody drug conjugates, and just a third class of drugs to mention is an oral type of HER2 targeted therapy called small molecule inhibitors or TKIs. And the one that sometimes gets used in early breast cancer after a year of something like Herceptin or Herzuma is a drug called neratinib. How do we use them? Well, typically women would receive or be recommended chemotherapy and HER2-directed therapy if their breast cancer was larger than 1 centimetre or if it was in the lymph nodes. But we do also give chemotherapy and HER2-directed therapy for smaller cancers as well. The main reason to give extra drug-based treatment alongside surgery for HER2-positive cancers is ultimately to reduce the chance of a return of breast cancer that might be fatal. And if we're giving the drugs before surgery, we call it neoadjuvant therapy. If we're giving the drugs after surgery, it's called adjuvant treatment. As you've heard, if a cancer is also hormone receptor positive, we use hormone therapies as well. The main monoclonal antibody or HER2-directed therapy has been Herceptin, and we now have the biosimilar Herzuma. And these drugs are given intravenously, which means an IV line or a drip is usually put into the back of the hand. They're administered once every 3 weeks. And the duration of treatment can be 6 months or 12 months. 12 months is probably a more common duration of treatment, but there'll be some scenarios or some women who are receiving a shorter course. Because that amounts to repeated insertions of an IV line, women are frequently recommended to have a port inserted, which is an access device that sits just underneath the skin in the top of the chest wall. And it means that when treatment's given, instead of needing to fish for a vein in the back of the hand, a special needle can be used to simply access that device for treatment. The monoclonal antibody drugs work a little bit like your own antibodies do. So when you have an infection or encounter a virus, your body goes into the business of producing antibodies to get rid of that infected cell. And the Herceptin and Herzuma drugs are engineered in a laboratory to behave a bit like your natural antibodies, but they are specifically targeting that HER2 receptor that's present on the outside of some breast cancer cells. Mostly these drugs are really well tolerated. There can be some infusion reactions, which leads people to feel hot or have a headache during treatment, and simple management with paracetamol is often enough to resolve that. One of the things we do need to monitor for is the potential effect on the heart. So there is a very low but important risk of causing some weakening of the heart muscle related to the use of these antibody drugs. And as you can't tell from the outside that that's happening, we use echocardiograms, which are an ultrasound of the heart, to monitor for the heart pumping strength. And often that would be undertaken around about once every 3 months. You've heard from Adele at the beginning that trastuzumab, Herceptin and Herzuma are words that we might be using interchangeably. That's because trastuzumab is the official name of the original compound, Herceptin is its brand name, and Herzuma is the biosimilar that is now available in New Zealand. Biosimilars are a replica of the original monoclonal antibody drug, and they need to go through a very vigorous process to be accepted for use. First of all, making sure that they are sufficiently similar to the original antibody, and then being tested to ensure that they are effective in patients. And also, after they're brought to the market, there's a monitoring program to make sure there aren't any signals of concern. And in recent times, we've had an announcement that from the end of this year, December 2023, Herzuma will be available to replace Herceptin, and by June next year, June 2024, it will become the principal HER2-directed therapy. And it's not exactly new to New Zealand. It's been available in the private sector for around about 3 years, and medical oncologists have no concerns about switching between these two drugs. Biosimilars are used in other cancer treatments, and the trastuzumab biosimilars have been used around the world for quite some time. One of the other themes in treating HER2-positive breast cancer has been that of escalation and de-escalation. So an example of that is for those who might have a very small HER2-positive cancer. And the goal is to try and give good treatment but minimize side effects. And one way to do that is to use just a single chemotherapy agent and give it as a small amount each week for 12 weeks, quite different to the types of treatments that you've heard about that are received in the neoadjuvant setting. So that's one way to de-escalate treatment when you've got a lower risk cancer. The other way to escalate treatment is to change the type of HER2-directed therapy that is given after surgery, and that's what Ellie was referring to when she described being on TDM1. TDM1 is a drug that is given after surgery when the main chemotherapy treatment has happened in a neoadjuvant setting. So around the world, it's extremely common for HER2-positive cancers to be treated by a neoadjuvant approach, and it's considered a standard of care option for cancers that are 2 centimetres or bigger, or if there are lymph nodes involved, but that doesn't mean it's going to be right for everyone. The key advantages from a neoadjuvant approach is that it can allow downstaging, which is shrinkage of the tumour, and for some people that will mean the surgeon can do a smaller amount of surgery. It can also allow cancer treatment to be started whilst there's planning for surgical operations or further investigations are happening. And from a medical oncology point of view, one of the key advantages from a neoadjuvant approach is that it allows us to really optimize the HER2 targeted treatments that are available. And that includes the use of pertuzumab. Pertuzumab, otherwise known as Perjeta, is a monoclonal antibody that's quite a lot like Herceptin, but it attaches to that HER2 receptor in a slightly different place. And when it's given in the neoadjuvant setting, it improves the response and increases the chance that there'll be 0 cancer cells left at the time surgery happens. Mostly it's really well tolerated. It does add some side effects, particularly diarrhea and rash. But the big problem is pertuzumab is not funded for use in this setting in New Zealand, and if someone is going to access it alongside their neoadjuvant treatment, they need to do so in the private sector at considerable cost. So you've heard a little bit about the response to treatment based on what's found at the time of surgery. And the technical term for a complete response is a pathological complete response, or a PCR. And this means that there are absolutely zero cancer cells to find when the breast is assessed in the laboratory and the lymph nodes. It's wonderful when this happens. We all feel very pleased when someone has their surgery and there's not anything left behind. But one of the advantages of a pathological complete response is that it gives us a more refined set of information to estimate prognosis, and it helps us to choose the optimal treatment to have after surgery. But it's important to know that a pathological complete response, or zero cancer cells left, is not essential for cure. It just is a very gratifying achievement that helps us to better adjust our post-surgical post-surgical plan. So after surgery, if someone's had a PCR, typically they would continue with their remaining cycles of Herceptin or Herzuma. They would have radiotherapy if that was indicated, and they'd be on hormone therapy if the cancer was also HER2 positive. If there was residual disease, i.e. there hadn't been a PCR, then it would be common for someone to move forward having 14 cycles of TDM1. This TDM1, which you might have heard of as Kadcyla, is one of the first antibody drug conjugates used in HER2 positive breast cancer. It's a really clever drug, which actually is Herceptin, but it's got a little bit of chemotherapy attached to it by a linker molecule. So in some respects, the Herceptin acts as the courier vehicle, delivering the chemotherapy just to the cancer cells that have got the HER2 receptor. Because it's got a little bit of chemotherapy with it, that's really the main reason that there are slightly different side effects associated with TDM1. And it can bring with it fatigue, it can bring some liver test changes, low platelets, which are the small cells that help with blood clotting, can cause a bit of diarrhea, and some neuropathy, which is numbness and tingling of the fingertips. This is also administered intravenously once every 3 weeks, and it's been approved and funded for use after neoadjuvant treatment in New Zealand since about July last year. Even though treatments for early HER2 positive breast cancer have really changed how we perceive and treat this cancer, there will still be a small number of women who develop advanced breast cancer where the cancers come back having spread to other parts of the body. But over the last 25 years, some of the greatest improvements in treating advanced breast cancer have come in the treatment of the HER2 positive cases, because we've had a real increase in wonderful targeted therapy specifically for this type of cancer. The main goals of treating advanced breast cancer that's HER2 positive are the same as the goals in treating any advanced cancer. And put simply, what we're trying to do is keep women as well as possible for as long as possible. Some of the drugs that we use to treat advanced HER2 positive breast cancer are now familiar. They're drugs like trastuzumab, or Herceptin, Herzuma, and pertuzumab. These are usually given together as part of the first step in treating advanced HER2 positive breast cancer, and they're usually, but not always, given alongside chemotherapy. We also use TDM1 or Kadcyla in New Zealand. That's mostly used as the second line of treatment. But there are some less familiar drugs that are often considered. These are not funded in New Zealand. These are the small molecule inhibitors. They're oral treatment. The main side effect of these drugs is diarrhea, and they're usually given alongside an oral chemotherapy drug called capecitabine. The one that's made the most in the way of headlines recently is a drug called tucatinib. And the reason that this has been of interest is that it looks like it is quite effective at treating breast cancer when it's spread to the brain. The other drug that's been exciting in the treatment of HER2 positive advanced breast cancer is a drug called trastuzumab deruxtecan, or Enhertu. This is another of the antibody drug conjugates. It's given intravenously once every 3 weeks, and this is not yet approved for use in New Zealand and is certainly not funded here. A little bit like TDM1, because it's that bit of chemotherapy attached, we do see side effects with it. And one of the things that's different with this drug is that the chemotherapy is not just delivered inside the cell, it's also delivered a little bit outside the cell and the environment around the cancer cell, and some of it leaks out of the cell. And it's for this reason that the side effects within HER2 are a bit closer to chemotherapy side effects. So that's things like fatigue, nausea. There can be changes in blood tests. About 40% of women experience hair loss, and importantly, there is a risk of inflammation in the lung, which we call interstitial lung disease. So what we actually do when treating HER2 positive advanced breast cancer depends a lot on what treatments have already been used, how long ago they finished, what drugs are available to that particular patient, and what the side effect profile looks like for that drug. Some people have said there's a bit of a traffic jam when it comes to new drugs for treating HER2 positive breast cancer. And not all of the options are available in New Zealand, but it's important for any woman with HER2 positive cancer to be asking their oncologist whether there have been, what drugs could we be considering, and to treat it as a bit of a team sport, trying to navigate the options. So.
Great. Thank you so much, Sheridan. That was very interesting, and we have a few questions to answer now. First question, someone's commented that she suffered from heart failure after having trastuzumab considering, and Sheridan, as you said, that's not common, thankfully, but is rare. Ellie, am I right in thinking you had some kind of heart thing associated with your...
I went from that normal heart down to I had about a 5% change in my heart. So it's just something that's being monitored. It's not something that I'm told I'll actually notice myself, but I've just gone down. It used to be really good and just come down about 5%.
So what sort of level do you tend to start worrying about this kind of thing? Yeah, so we would be pretty comfortable with what's called an ejection fraction, which is a measure of how much blood is pumped out of the heart each time it squeezes. And you might have thought that it should be 100%, everything should get squeezed out. That's not the situation at all. Anything above 50% would be considered normal. If the level or the percentage is lower than that, then an oncologist would be a bit twitchy about giving Herceptin. So we're looking at both what the percentage value is, but also at what the change is. So if someone started from a level that was 70 and then all of a sudden they're 50, even though 50 is normal, that's too much of a drop to accept. And if that's happening, a number of things would occur. You would potentially suspend the Herceptin depending on the exact numbers and any other medical problems, and you might engage a cardiologist to start cardiac medications if you were really worried. For most people, but again, not everyone, so I feel like I say that a lot, the problem is reversible. So if you take a break, you would expect to see some improvement. But there's definitely women who experience a decline in their heart function who don't get the improvement we would have predicted.
And I have heard patients say that their oncologist referred them to a cardiologist before they even started Herceptin. Is that common?
I think that would usually be restricted to those people who might have had a high risk for already having a heart problem, so might have had another medical problem that increased their risk, or had maybe had a history of a low ejection fraction on an echocardiogram. Those would be common reasons to connect someone with a cardiologist.
Great. Okay, thank you. Now, a question from someone who says she had a very small invasive HER2 positive breast cancer, 4 millimeters plus some DCIS. She says, I've had surgery, start radiation soon, then tamoxifen. Is there a higher risk of recurrence with HER2 positive?
Yeah, so the short answer is yes. but it's still, for a cancer of that size, still an incredibly good risk profile. And the job of an oncologist is to make a treatment decision that balances the risk of a treatment and the benefit of a treatment. So even though if you were to compare a 4mm cancer that's hormone positive and HER2 positive with a 4mm cancer that's hormone positive and HER2 negative, it's the HER2 negative cancer that might win slightly in terms of long-term risk. They're both really good risk situations. So it would be uncommon for chemotherapy to be warranted for a cancer that had a good prognosis like that.
Interesting. Right. And okay. And so then next question, someone with HER2 positive advanced breast cancer, and you sort of covered this slightly, Shirley, but interested in hearing about HER2 treatments that may work better for brain metastases than Herceptin and Perjeta.
Yeah, so we've always sort of had the concern that the drugs we use don't get into the brain very well. Your brain's really good at protecting itself. It doesn't want the poisons in there. And so you have a fancy network of blood vessels that we call the blood-brain barrier. And a lot of our drugs probably don't get across that barrier very well. In the current era, the new HER2 targeted drugs, so that's Enhertu or trastuzumab deruxtecan, and tucatinib, which is an oral small molecule inhibitor, they actually have been shown to reduce the size of brain metastases in advanced HER2 positive breast cancer in a way that we don't see with the other HER2 targeted drugs. So they are now on the list of possible ways to treat brain metastases, but local therapy, so that's usually radiation and surgery, still is the primary way to treat brain metastases.
Okay, thanks. Now here's a good question. If why are there 14 rounds specifically of the drug, I guess Kadcyla, given after surgery when there's still cancer cells there? So sounds like a lot.
Yeah. So short answer, because that's what they did in the study, and the oncologists don't make it up. You might think it's a big black box, but we actually try very hard to do exactly what was done in the clinical trials, because that allows us to then give you some estimates of benefit and risk. And in the key study where the Kadcyla after surgery was done, everyone got the 14 treatments. And you can kind of see why they picked that number though, because for treatment with Herceptin, it's usually 1 year of treatment, and many women will have had, which is about 17 treatments, many women will have had 3 or 4 of their Herceptins with their chemotherapy before surgery. So what you're kind of doing is adding on the balance of the year in the post-surgical phase, and 14 is a number that closely fits for most people.
And if you have had a complete response, like Sarah did, why can you just skip the after surgery treatment?
Well, they didn't let me, so no, I don't know. That's true.
Yeah. So we certainly wouldn't advise that. And why not? Because it hasn't been done, and so we're not sure how much you'd miss out on. When the big studies were happening with Herceptin, and there's more than 10,000 women represented in those studies, so it's good, strong data. Everyone got a year. In fact, one study they gave longer, but that is what made the 1 year of Herceptin the standard. And then over time, there were some extra studies done looking at shorter durations. So until we have proof that you can shorten the amount of post-surgical treatment, we wouldn't want to take a guess and expose someone to that loss of benefit.
Okay, and a question now for Ellie and Sarah, actually. What was the hardest decision to make among those treatment decisions you had to do?
Do you have the answer?
Yeah, what she said.
Probably for me, my change decision to go from, I was hoping just a lumpectomy to full mastectomy, and probably also managing not so much my husband, like we made decisions together, but family around that, like they were then worried, like what is that? Oh, does that mean it's worse than it is? So that was probably the hardest one in terms of decisions. For me.
I think IVF was a decision I just didn't think I was going to have to make, because I hadn't really thought about chemotherapy. I just hadn't thought about how treatment would affect your fertility. It just hadn't crossed my mind, and amongst everything. So that was, because basically it was just checking, do you want kids? Just decide now. And you're like, oh God. So that was quite a big, and amongst everything else. But actually probably the hardest decision was whether to have a single or a double mastectomy, even though my breast surgeon explained to me very clearly why a single mastectomy was a great choice for me, because like you say, everyone else goes, but aren't you just worried about the other breast, and doesn't make you think that it's going to come back? And I really had to get my head around that and be really comfortable that I wouldn't be freaking out afterwards that I've made the wrong decision and having anxiety around that. So that's probably sort of similar to you, actually. But now I'm really happy with my choice. If anybody else is in that predicament.
And so in terms of drug decisions, that sounds easier for you than the surgery decisions.
True. I didn't even talk about drugs. You just get told you're having them.
I think there was a point in time where the throwing in the pertuzumab, you can get this through private, but you can't get it public. I'm like, well, what does that mean? Is it properly tested? What will, what is that? What will it mean for me? And just talking about it, it'll give you an extra 5%. It's like, you know what I mean? Like just trucking drugs at my body was not my aim either, even though I let the expert make the decision. It was like, well, what does that drug do? What does it mean? Is it going to double whammy me in chemo? You know what I mean? Is it going to make what would be a normal chemo experience worse? Things like that. So, but also feeling privilege about, actually I've got some options here that not everyone maybe necessarily has. So weighing up those sort of thoughts and feelings.
And I think figuring out where you're at when you're going into treatment, like at the time I felt like before I'd found my cancer, I felt sort of fit and healthy. So in my head I was like, please just, I'll trust, like you say, trust the experts. But just, if you could just nuclear bomb me, that'd be great. Just throw it all at me, please now. That's how I really felt. And so it's just, if my oncologist recommended something, sounds great.
So Sharon, how does that sort of balance play out?
So it's sometimes it's not a kind thing to do, to give people options, but we also don't practice paternalistic medicine. My job is not to tell you what to do. It's to make a recommendation and then work to a decision with you. And there's different types of chemotherapy backbones that the drugs can be given with. So sometimes there's a decision around that. And then there's the funded and unfunded medicine parts. And look, that's a really difficult conversation. It's hard to be seen to be promoting someone that's going to cause financial toxicity, or that's going to be completely out of reach for someone, but you never know. So we do have an obligation to talk about drugs that are considered international standard of care, that are available in New Zealand, even if they're not funded. We actually have a medico-legal requirement to at least let people know that they're out there, and then help them find out more, help them take that further if they want to. So for the neoadjuvant pertuzumab, that's non-controversial in terms of where it sits in treatment recommendations, but it's highly controversial because it's not funded.
And in fact, someone has asked when might we see these new treatments available in New Zealand, and that is the $64 million question. That there are certainly applications into Pharmac for a lot of these medicines. We don't know how long that'll take. Anything to add to that?
No, I agree. I wish I knew. They're really expensive drugs. These are not a couple of $100 drugs. These are many thousands of dollars, sometimes tens of thousands of dollars per dose drugs. So they're not decisions that even Pharmac is going to be making lightly. We'll cross all of our fingers.
An encouraging comment from someone to say that her heart did return to normal after she was treated for. Yeah. And another comment on drug funding. A 17-year breast cancer survivor who purchased Herceptin for $86,000. So that was obviously pre-2008. I'm grateful for the support of our local community who helped fundraise, with the remainder going on our mortgage. So it's a huge thing.
Yeah, wow.
And it was a drug that was worth doing that for.
Yeah.
It's been a game changer. So
yes, and so I hope 17 years later your mortgage is paid off. But yeah, it's a big decision for people. Let's see. So Sheridan, I think another drug question. After finishing TCH 6 cycles and now going through Herzuma 11 sessions, Perjeta was considered, but the benefit of adding it is 2%, small, not effective return on investment. Should I rediscuss adding it with my oncologist?
yeah, so the use of pertuzumab after surgery, the study that was tested in, we were all disappointed that it wasn't more effective, because it's really effective in the before surgery setting, and it's really effective in the setting of advanced breast cancer. But when you simply add it on to Herceptin after surgery, it's a little underwhelming and tends to be reserved for people who have got particularly high risk features, including those who've got a high number of lymph nodes involved, or possibly those who don't also have hormone treatment to form part of their plan. So it's always worth having the conversation again, but it's not widely used because it cost, and also the fact that most of us feel it's restricted to those who fall into a particularly high risk group. But it's always worth having the discussion, even just to be clear on options or not options.
A question in the advanced breast cancer space. What are your views on Ibrance and Herceptin and HER2?
So the initial Ibrance is an oral drug that's given alongside hormone therapy as part of treatment for advanced hormone positive breast cancer, and it's one of a family. The family of drugs are called CDK4/6 inhibitors, and in all of the studies where those drugs were being tested for advanced hormone positive breast cancer, they didn't have HER2 positive cancers in them. So for an oncologist, what that means is we don't know if those CDK4/6 inhibitors like Ibrance work as well or work the same way in the HER2 positive, hormone positive subgroup. One study called the Patina study, which was an international study that closed a year or two ago. I can't remember exactly. We were part of it in Auckland, so there will be some people that you'll come across who did that study in Auckland, and that's exactly the question that was being asked. For women with advanced HER2 positive breast cancer that's also hormone positive, can you get a better outcome if you give them palbociclib Ibrance as well as all their standard stuff? So we don't really know. I think we'll know really soon, based on that study having gotten to a point where results might soon become available.
Right.
The special authority criteria for Ibrance in New Zealand are restricted to hormone positive, HER2 negative patients.
Okay. A question again for Ellie and Sarah. When you were diagnosed first up, what was your understanding of the HER2 positive and what that actually meant? Did that kind of register?
I had no idea.
Yeah.
I mean, so much of it didn't. It was, I mean, breast cancer is, there's so many different types, as you've said, and it is, the more you dive into that diagnosis, the more new words are being thrown at you. And I had no concept of what HER2 positive meant. And thank goodness I had a very patient oncologist who drew a lot of diagrams and that looked like great hand drawings of what you showed in a beautiful setting just before. But yeah, no understanding whatsoever. And I felt like what I understood about breast cancer by the end of treatment was just light years away from where I started. Yeah.
Yeah, I thought I was impressed to remember the word neoadjuvant. And yeah, definitions of things. I think in that early diagnosis phase, I wanted to get on with stuff. I was less into the definitions of things. Does that make sense?
Yeah.
And now as I'm getting through that, I'm adding more to my toolbox of what these things mean, if that makes sense. It's like, I want to get on with this. Do I need to know what it means from a scientific point of view? Probably not right now. Yeah, as I said, pretty happy to walk away with knowing what neoadjuvant. That one.
Okay. Cool. A question, Sheridan, where does someone who is low risk HER2 positive, not recommended chemo, but has lymphovascular invasion? So she says, at the time of diagnosis and surgery, I didn't understand the potential seriousness of lymphovascular invasion, LVI, and it concerns me as 2 people I know have progressed to stage 4. Okay.
Yeah, so that is one of a range of features in a cancer that we use when we're estimating risk. And there's a little bit of, I want to say, controversy around lymphovascular invasion, because it can be a difficult thing to be accurate about. It's something that pathologists see when they're looking under the slide, and effectively what they're seeing is cancer cells trying to make their way into little channels that might be blood vessels or that might be little lymphatic channels. But in the process of preparing the sample to look at down the microscope, there can be some artifact as well. And I think sometimes that there's concern that maybe that reduces the opportunity for being really 100% accurate about that. And for that reason, lymphovascular invasion isn't built into our mathematical modelling about risk. We use things that are a little easier to pinpoint, like grade or size or lymph nodes. And the reason I'm giving you that backstory is because it's not always used as a strong indication to have chemotherapy, because it might be trumped by the lymph node involvement, or it might be not so important if the cancer is really small. So even with that, it's low risk. It's seldom enough on its own to really drive a decision, but it's certainly considered as part of a decision-making process.
Okay, great, thank you. Someone's just noted that although she didn't pay for neoadjuvant Perjeta, she still achieved a complete response on her treatment just with Herceptin and chemo. So yeah, that's good.
Awesome.
Good to hear. Are there any lifestyle choices that help to prevent recurrence of HER2 positive breast cancer specifically?
Not that I'm aware of.
Not that I'm aware of, no. Lifestyle choices around not gaining too much weight after chemo and exercise and things like that are really the only things that have a solid body of evidence.
Yeah, that's right. The evidence around those two things is pretty solid. There's the alcohol evidence as well. And there's lots of other ideas. Not quite the same as evidence, and they're possibly good ideas, but not
absolutely. But none of them are specific to HER2 positive.
Not that I'm aware of.
Great. Okay. Right, we're nearly done here. Just one other question we've got here. My friend had her Herceptin as sort of a regular injection, not like chemotherapy. How does that work?
So there are 2 different ways that Herceptin can be given. It can be given intravenously, which is you've got to put a needle into a vein or into a port. And there is also what's called a subcutaneous formulation, which is where the needle is just inserted into the soft part of the tummy. And it's similar to the way you might give an insulin injection or a blood thinning injection. So that's subcutaneous Herceptin, and it's not what we have funded for use here.
Right. Do people choose to have that? Or
there will be some, it would have to be private sector again, and it's, so yes, there will be a few people around who for some reasons have had it, but probably not many. Yeah.
And a couple of other questions have just popped in right at the last minute. do you consider metabolic therapy to be advantageous?
So that would be out of scope for me to comment on that. It's not something that I have enough knowledge to be sensible about. Sorry.
Okay. And lastly, 6 months versus 12 months of Herceptin. Is this common and is it as effective?
Yeah. So what that's referring to is the idea that possibly 1 year of Herceptin is not necessary, that possibly a shorter duration is sufficient. There's 2 really big studies that looked at that, looked at 6 months compared with 12. And they both gave slightly different answers, which has left us all scratching our heads. But what they did show is if you just look at the numbers, not at the statistics, if you just look at the numbers, there was very little, if any, difference between 6 and 12 months. So there are definitely scenarios where someone might have 6 months only. And it also means that if we see a drop off in heart function, we don't feel so disappointed that someone might not be able to continue. The majority of women would still be considered for 12 months, but it's true that there's probably little difference.
Great. And thanks again to Sarah, Ellie and Sheridan. If you have any questions about breast health and breast cancer, our nurses are available during office hours to take your calls. The number's there on your screen, and do consider joining our MyBC community of breast cancer patients on Facebook. That's it from us. Thank you. Good night.